Hey everybody, and welcome back. I know it's been a while, but I'm back at it, so let's kick this off. Today we're going to be talking about neonatal hyperbilirubinemia. Okay, hyperbilirubinemia. Okay, so first things first, why do we care about this, right? So the reason is because there is a risk of neurotoxicity. Uh, uh, Babies can get what is called BIND, bilirubin-induced neurologic dysfunction, previously known as connectivitis, right? So this is a triad of cerebral palsy and gaze palsy and hearing loss. So this is why we care about neonatal hyperbilirubinemia. We care about babies not getting it. Okay. Now let's move on to the next thing. So why? Give me a sec. Yeah. So why are neonates susceptible to hyperbilirubinemia? So the first thing is that they have fragile RBCs. That's just the way it is, and then it is compounded by the fact that there is a change in hemoglobin from like hemoglobin F to hemoglobin A. So this is just like a very volatile situation going on here. The second reason why is because they have a sterile gut. So generally what happens in adults is that I'm going to change the color and talk about that. So generally what happens in adults is that you have conjugated bilirubin in the gut, and the intestinal flora, right, convert it into stercobilin, which is what gives the color to stool, and basically most of it just gets excreted out in the feces. Now when you don't have your intestinal flora, what's going to happen to this conjugated bilirubin is that it's going to get converted into unconjugated bilirubin by the action of beta-glucuronidase on the intestinal beta-glucuronidase on the brush border of the intestinal cells, right? So that is the threefold reason why. And another reason is also because and this phenomenon is called breast milk jaundice. It's because breast milk itself has the enzyme which is beta-glucuronidase, and that sort of causes deconjugation of the bilirubin, which again gets reabsorbed, and that causes, basically there is a state of increased enterohepatic circulation, which increases the risk for hyperbilirubinemia in neonates, right? So what would be the predisposing factors to developing neonatal hyperbilirubinemia, right? So the first set of disorders you want to be thinking about is something to do with the red blood cells, right? You want to be thinking about G6PD deficiency, right? You can be thinking about ABO and RH incompatibility between the mom and the baby. This would cause your RBCs to burst at a quicker rate, and that can cause neonatal hyperbilirubinemia. Another set of conditions could be a cephalohematoma, right? And anything that causes significant bruising, right? significant bruising to the baby. And you also want to be thinking about intestinal motility issues. Intestinal motility. And breast milk failure. Okay, these two, because feces are the main way that bilirubin leaves the body. So if you're not able to excrete it out, you accumulate it, and that's why you get hyperbilirubinemia. I forgot to mention a very important concept. I cannot believe I forgot that. One of the other biggest reasons why babies are susceptible is because the enzyme in the liver, which is the UDP, glucuronil transferase, the activity is very low. It's the liver is still immature, it's developing, and so is this enzyme. It's not functioning very well in a neonate, and that's also one of the reasons why they are susceptible. Okay, now let's talk about at what blood levels you would be classifying it as neonatal hyperbilirubinemia. So if up to 25 milligrams per deciliter, this is considered physiological, right? Physiological. Now if it exceeds 25, then you would be worried about bind. And when it exceeds 30, you call it extreme hyperbilirubinemia. Okay, and so what would be the ominous signs, like when you have to be looking out for bind or considering an exchange transfusion for a baby? Ominous is if the onset of jaundice is within 24 hours after birth, right? And then if there's like a rapid rise in total serum bilirubin, and if this persists more than 2 weeks, so that would be flagged as like very abnormal. So what would so there's like the diagnosis is twofold. First of all, there's like total serum bilirubin more than 25 milligrams per deciliter, and then there is a TCB device, and on that you want to be getting more than 5.15 milligrams per deciliter, but this is not very reliable. This is gold standard for diagnosing it. So what would our clinical manifestations be, right? So the clinical manifestations are yellowish discoloration of sclera and skin, right? And then the baby, if it's very severe, can develop bind. The triad is cerebral palsy, gaze palsy, and hearing loss, as I mentioned before. Now let's talk about management, right? Give me a sec. Yeah. So the main thing you first want to be doing is adequate nutrition and hydration. So this is what sort of encourages bowel movements and causes more of the bilirubin to leave the body. So it encourages bilirubin excretion. So that's like the first most important thing you want to be doing. You also want to monitor the baby's vitals, right? You want to monitor their urine output, temperature, and all the normal jazz, right? Now it's important to note that the the most preferred way to feed the baby is through enteral feeds, right? Expressed breast milk, so that you sort of because we are talking phototherapy here, right? Because I mean, I'll obviously come to that. But you want to be giving them express breast milk, because if you take them away from the phototherapy for frequent feedings, it sort of impedes the effect of phototherapy. So express breast milk or pasteurized donor milk is the most preferred way of feeding the baby. And in a resource limited setting, they use like indirect filtered sunlight for like mild to moderate. But if it's like severe, that won't work. To be honest, phototherapy is the gold standard. It works by I want to be talking about phototherapy. It works by converting bilirubin to lumirubin, which is soluble, so it sort of gets excreted via the urine. And yeah, so obviously along with all of these, you want to be monitoring total serum bilirubin. Sorry about that. Yeah, so you put the baby supine, right? The baby also has an orbital shield to shield the eyes, and caregiver interruptions are only allowed after the TSB level drops below 20 milligrams per deciliter. Okay. Now let's talk about the indications for IV hydration. Pick something blue. Okay. Yeah, this is good. Indications for intravenous hydration. So the first thing is that if the baby has poor feeding, which is pretty obvious, you want to be opting for IV hydration. If the baby has hypovolemia or hypernatremia, right? If phototherapy fails, we go for a more advanced modality called exchange transfusion, right? Exchange. But again, this is reserved for really severe cases. Done in a NICU or a PICU setting, typically for babies that have more than 30. And it also depends on another factor called the BA ratio. So the way that the BA ratio works is basically it's a bilirubin to albumin ratio. And if this ratio is high, it means that more amount of bilirubin is in the blood. In fact, it has taken up the binding sites on albumin. That means that there's more free bilirubin in the blood as well, and that's like free to sort of go across the blood-brain barrier and cause bind, right? So that's the reason why this is one of the parameters along with TSB that can be used to determine the need for an exchange transfusion. Now, one more thing that I do want to talk about is there is IVIg. This is typically given for babies that have developed hyperbilirubinemia from hemolytic etiologies. It sort of like stabilizes the red blood cells and decreases the fragility of the blood cells, and this is only used in like a subset of patients. It's not used every time, but it really depends on the etiology and response to treatment. So that's pretty much everything I wanted to say about neonatal hyperbilirubinemia. There's up to 25 and resolving within 2 weeks is benign. Otherwise, it's going to be moderate slash severe, and we have discussed everything else that goes into managing such patients. Thank you so much for listening. If you have any specific requests for topics that you want me to cover, please let me know. I would be happy to do it. I'm always looking for ideas. Thank you for listening. Thank you so much for tuning in. I hope you're having a great Friday. I will see you guys next time. Good luck.